Slides, please. Revati ma'am, please.
Our screen.
Yes.
Good evening, everybody. Good evening, everybody. Welcome to Chennai Menopause Madurai chapter. Welcome, faculties and delegates. Revati ma'am, please take over, ma'am.
Thank you. Good evening, dear friends. I welcome you all to this IMS Madurai chapter CME. As you all know, following zonal conference, we have started conducting monthly CME on every first Sunday, and it is going on very well. And incidentally, we have got special webinars also in between on special topics. Okay, and we would like to do even more, for which we are planning to have a meeting of our members at the end of this session, in which we will discuss about doing more and more for the society. And it's my great pleasure to welcome our chief guest, Dr. Hepzibah, chairpersons, Dr. Mahalakshmi and Sivagami, and speakers, Dr. Sudhadeep and Dr. Niranjanan, and all our members and all the delegates. And I wish this meeting is going to give you a lot of input, a lot of knowledge on osteoporosis or bone health in menopause, as well as adult immunization. Welcome you all. Thank you. And one more thing is that I'm happy to inform you that the 3 members from our society participated in SIMP exam, got through successfully. Let us give a big hand. Okay, to you. Lighting lamp and the prayer, Priya.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you. It's my great pleasure to welcome our chief guest, my close friend, Dr. Hepzibah Kribamani. She is President, Chennai Menopause Society, former superintendent of Stanley Medical College. At present, she is professor in Savita Medical College, past president of OG Society, that is OXY, and past president Menopause Society Education Committee. All of us know when she has done a lot of work on that, and she also came to Madurai and participated in the IMS Madurai chapter program. She's a research member secretary, Savita University. And I think in which topic you got PhD? I don't remember. She got PhD also.
Fetal medicine, ma'am.
Yeah. She conducts awareness program for Tamil Nadu paramedical staff, schools and colleges. She has presented and published many papers in Index Journal and Reviewers for a list. And she is a PhD guide for SRMC Savita. She has got a lot of awards to her credit, and she has developed midlife and beyond apps. She has sent to me. It is really very nice and useful, and I wish it should be utilized by the IMS. And she has written textbook on video embedded undergraduate manual of clinical obstetrics and gynecology, 3rd edition. And at this juncture, I would like to mention one important thing. When I had been to Velamol for some model exam, the student said, "What book you are following?" Hepzibah Madam's book on clinical practice, OG. Okay. Handbook on USG for training MBBS doctors, and Foxy Focus she has written on endometriosis and menopause. Over to you, Dr. Hepzibah, to say a few words.
Very good evening to one and all. I respected President Dr. Revati, the chairpersons Dr. Sudha, Dr. Bakalakshmi, the Sivagami, the speakers, and Dr. Niranjan, and dear friends. I really deemed it a great honor to be with you all this evening. My sincere thanks to Dr. Revati Madam and her entire team. Madurai Menopause Society is always continuously dissipating the knowledge. Madam was telling every month, Sunday, they are having a CME and they are doing various awareness program. Madam is very keen on doing awareness program. The dedication with which Madam and the team, the entire team is doing the great spirit also of them. She creates that sense of spirit among with you all. And she was telling me the 3 people from your society has become a SIMS. They have cleared the SIMS exam. So I was amazed by that. And the topic, every program I used to attend, the topic and the speakers, they select meticulously and really amazed by that. And today also we have an important topic, the bone health. See, we all know the osteoporosis is a silent killer. You should know when to start the hormones, when to do DEXA, and how long to give hormones, when to switch over to the other doctors. It's a big dilemma for us. We do not know properly. And similarly, the vaccination also, adult vaccination, we just don't bother. When they go to Kumbh Mela and come to us, we do not know what to give. When they go for Hajj, we do not know what to do. And now with the COVID, we all know when to give, what to give for the adult also. And I know Dr. Niranjan personally. He's a fantastic surgeon and an eminent speaker. He has done a lot of publications. And he's a very good teacher also. Actually, Thayapol, academically interested. And I'm really inspired by the Dr. Revati Madam, both in academic activities and in extracurricular activities. And I'm sure, and Dr. Sudha has done with the ICMR for a long time. So she must be really good in guidelines, the proposal and other things. So this CME also, they have chosen a right topic and a right speakers that speaks about Madurai Menopause Society. Recently, we were with one national CME. We do not know what they are talking. So that is the speciality about Madurai Menopause Society. Once again, I thank Dr. Revati Madam, the entire team for making me for a part of this CME program. Thank you so much, and I wish you all the best in future endeavors. Thank you.
Thank you, Dr. Hepzibah, for your presence here and honoring us. I hand over the session to Dr. Lakshmi. Dr. Lakshmi is a consultant gynecologist, Lotus Fertility Center and NTC Hospital, Madurai. She was the Joint Secretary of Madurai OG Society 2013 to 18. She was Secretary of Madurai OG Society, Organizing Secretary of MOG's 26th Annual Conference in 2020, which was a hybrid conference which went on very well and very well appreciated by Foxy. And she has received Foxy Dr. C.L. Javeri Prize and at AACOG 2020 Lucknow, and also Wonder Fox Vision Award. And she has published articles in national as well as international journals. I request Dr. Lakshmi to take over the session.
Thank you, madam. Thank you for your sweet words. So I'd like to introduce our chairpersons for our today's session. Dr. N.K. Mahalakshmi, Professor, OG Department, Madurai Medical College, Government Rajaji Hospital, Madam, Madurai. Madam doesn't require introduction. Currently, she's a professor in OG Department, MMC Madurai, and Madam was Secretary of Madurai OG Society in 2016 to 18. She was in the organizing team for the UA Foxy 2016 and Silver Jubilee Conference of MOX. And Madam has worked as professor in Tirunelveli and Theni Medical College and also district EMOC trainer for many batches. She's presented free papers and posters, and she has won award for 20 years of government service from District Collector of Madurai, many publications and special areas of interest of management of high-risk pregnancy. I would like to introduce our next chairperson, Dr. Sivakami Ilango, MBBS and MD, consultant obstetrician gynecologist and gynec lab surgeon. Madam has done her UG in Tirunelveli and MD from Stanley Medical College, Madurai. She's got a diploma in laparoscopy at Indian Institute of Laparoscopic Surgery, life member of CELSI, had been in Tamil Nadu government service for 25 years and as OG faculty in Department of OG for 12 years. And Dr. Sivakami, Madam, is thrice a winner of CS Dawn Prize in All India OG Congress, Foxy, had been faculty in various sessions, panels, and workshops. And her areas of special interest are gynec, laparoscopy, and high-risk pregnancy. And Madam is director of Subham Hospital, a multi-speciality care center in Tirumangalam, Madurai district. Over to the chairpersons. Dr. Sivakami, Madam.
Thank you, Lakshmi, for the nice introduction. Thank you, Lakshmi. Dr. Sivakami.
Thank you, Lakshmi, for the nice introduction and your kind words. Now, let me introduce Dr. Sudhati for one of our speakers today. We all know in Madurai, she is a senior person, senior private practitioner for the last 35 years with the areas of interest in OPSI and gynae. She worked in ICMR Family Planning GRH Madurai. She is an alumni of Madurai Medical College, and she is a co-founder of Taj Multi-Speciality Hospital Madurai and the co-founder of Top Kids Foundation. Welcome you to the IMS Forum Madurai, Madam. Over to you.
Good evening, dear friends. I'm thankful for this short and lovely introduction. I would like to thank our IMS. Am I audible, ma'am?
Yeah, yes, ma'am.
Ma'am, you can just go to the slideshow, madam.
Slideshow.
Full screen.
Full screen.
Yeah.
Yes, ma'am. I would like to thank our IMS President, Madurai Chapter, Dr. Revathi Janaki Raman, for giving me this opportunity to speak on this unusual and scarcely discussed topic, adult vaccination. The most cost-effective strategies available in public health today is vaccination. It protects the community by preventing the spread of this infectious disease. Most of the dramatic success is the eradication of smallpox and polio from the public health. Vaccines help to protect the community by reducing the spread of infectious disease. Many infectious diseases have become rare or has been eradicated now as a result of aggressive immunization programs. The Universal Immunization Program, or as it known as UIP, it was launched in 1985. It was aimed to reduce mortality and morbidity from 6 vaccine preventable diseases: MMR, influenza, pneumococcal, HPV, zoster, and DPT. It's one of the largest public health programs targeting about 2.9 crore of pregnancy women, and it has really been playing a very significant role throughout. Major guidelines: all these adult vaccinations, they depend on previous immunization received during childhood and varies from region to region. The major guidelines, ACIP, or Advisory Committee on Immunization Practices by CDC or Center of Disease Control. WHO guidelines, and Association of Physicians of India. The vaccines recommended for healthy adults in India: MMR, DPT, influenza, more than 50 years, pneumococcal, more than 65 years, HPV from 19 to 26 years, but it can be extended up to 49 years, and zoster. These are the vaccines which are recommended for high-risk individuals. They are hepatitis B, hepatitis A, meningococcal, varicella, typhoid, rabies, and cholera. Now, why immunization is important? Vaccines prevent more than 20 life-threatening diseases, helping people of all age to live longer and healthier lives. In a country like India, with huge population, vaccine can be a major intervention in preventing morbidity and mortality and disability due to infectious disease. Now we should know, why is it important? We have seen massive diphtheria epidemic in former Soviet Union, which has about 150,000 cases with 5,000 adult deaths. Outbreak of MMR caused major disruption in college campuses seasonally. Large economic loss directly and indirectly. Community-acquired pneumonia, or CAP, has about 155.8 million cases, episodes globally, and contribute to about 1.9 deaths annually. US alone has about 36,000 annual deaths related to influenza. HPS-AG carriers in India is estimated to be over 40 millions, around 2.5 lakh deaths related to chronic hepatitis in India. Tetanus causes nearly 3,09,000 deaths annually. So there are many bottlenecks that we face for these adult vaccinations. Adult immunization is a very selective and it is not universal. Different vaccines have different target groups. Healthy adults are harder to reach through public health system. Counter-specific risks such as travel, high-risk behavior, and immunocompromised state. Barrier to adult vaccinations are much more lack of surveillance, lack of national guidelines, lack of coordinated adult vaccination programs, treatment taking precedence over prevention, lack of provider recommendations, cost, and lack of recognition of benefits, efficacy, and safety. Strategy: reaching out to adults. We should have increased demand for adult vaccination by improving provider and public awareness. Ensure healthcare systems have an adequate capacity and strategies to deliver vaccine to adults. Ensure adequate financing mechanism to support the delivery of vaccine to adults. Ensure adequate support for research. Now, after all these, we come down to influenza vaccines. I'm just going to touch upon these vaccines, which are very important for the adults. First is influenza vaccine. It is foremost amongst disease preventable by vaccination and virus that is associated with serious adverse events leading to hospitalization, debilitating complications, and death in elderly individuals. Immunization is the cornerstone for preventing these adverse outcomes. It is available as chilled vaccine to be given intramuscularly. Single dose inactivated flu vaccine, 0.5 ml intramuscular in deltoid region. Nasal spray vaccines, live attenuated vaccines are also available, but that they are not that popular. As it constantly mutates, a new batch has to be prepared every year. So it becomes a constant problem every year that we have to face. Becomes effective after 2 weeks. Peak season begins in October and lasts till May. And so the best time to give vaccination is October and November. There are many allergic reactions. Few of them I've highlighted, mainly Guillain-Barré syndrome can occur. DPT vaccines. Now DPT is not available. Only TD vaccination is available. This TD vaccination should be administered regardless of when a tetanus or a diphtheria toxoid was last received. It is indicated for adults from 18 to 64 years, every 10 years till the age of 65. 2 doses of Tdap or TD 1 to 2 months apart, 0.5 ml intramuscular. Women planning pregnancy or in second and third trimester should be given this vaccine. It is contraindicated in persons with anaphylaxis and history of encephalopathy and unstable neurological conditions. There is a nationwide expanded program on immunization policy of Government of India, which has targeted women planning pregnancy or in second or trimester, Tdap can be given. Acellular pertussis vaccine or 0.5 ml intramuscular is contained a lower concentration of diphtheria and pertussis toxoid. Therefore, it is nowadays advised for pregnant women at 28 to 32 weeks. Next comes the pneumococcal vaccine. Lower respiratory tract infection, including community-acquired pneumonia or CAP, is important cause of morbidity and mortality worldwide. Pneumonia, bacteremia, and meningitis have associated with fatalities rates of 34% respectively, and 23% were older than 50 years. It is available in two forms, polysaccharide vaccine 23 serotypes or PPSV23 and conjugated vaccine with 13 serotypes or PCV13. PPSSV23 is less immunogenic. It promotes herd immunity and protects from respiratory tract infections. Conjugated vaccines with 13 serotypes or known as PCV13, this is highly immunogenic, results in mucosal immunity and has a lifelong effect. PCV13 is approved in India for use in adults more than 50 years for prevention of pneumonia. It can be given after 1 year and 5 years apart. Dose is 0.5 ml, single dose intramuscular. Hepatitis B vaccine. Hepatitis B causes a spectrum of liver disease, including self-limiting hepatitis, acute fulminant hepatitis, and chronic HBV infections. It is a recombinant vaccine. This vaccine is indicated for all the unvaccinated adults at risk of HBV infection and all the adults seeking protection, including post-exposure prophylaxis. Also indicated in high-risk people with exposure to blood and blood products, household contacts, elderly, healthcare workers, HIV-positive individuals, commercial sex workers, etc. The dose is 20 milligram in adults at 1 to 6 months interval. Booster dose may be administered when the HBs titer level declines below 10 MIU per ml. Above 65 years, booster dose is not required. The next is human papilloma virus. HPV is one of the most common sexually transmitted infections. It is associated with more than 95% of cervical cancers, which is the second most common cancer in women worldwide and the commonest in India. HPV serotypes 16 to 18 account for nearly 76.7% of cervical cancers in India. HPV vaccine is a recombinant vaccine, DNA vaccine. Two types are available. Most effective when administered before the onset of sexual activity. The dose is 0.5 ml 16 months in age 9 to 26 years and can be extended up to 46 years. There are two types, quadrivalent and bivalent. Quadrivalent, also known as Gardasil, has HPV serotypes 6, 11, 16, and 18. It is licensed for prevention of vulvar and vaginal precancers and anogenital warts. Recently, I've heard that there is a new Gardasil vaccination that is coming, very expensive, somewhere it costs around 11,000, which contains about 7 serotypes. I don't know whether it's still in the market or not. And the other type of vaccine is bivalent, or the HPV 16 and 18, also known as Cervarix. This is used in females as young as 10 years. It is designed for a prophylactic use only. They do not clear existing HPV infection or treat the HPV-related disease. Next is meningococcal vaccine. Meningococcal disease is an acute bacterial disease caused by gram-negative capsular diplococcal bacteria. It occurs worldwide as endemic infections. In India, the disease is endemic, and in some states like Delhi, Haryana, UP, Rajasthan, West Bengal, Orissa, these are the places where it is endemic. This disease is preventable through vaccination. Routine vaccination of all adults is not recommended. It's a quadrivalent vaccine. Two types are there: meningococcal polysaccharide or MSV4. It can be used only more than 2 years of age, that is pediatric age group. Meningococcal conjugate vaccine or MCV4 is available, provides herd immunity, reduces nasopharyngeal carriage, and provides long-lasting immunity. This vaccination is indicated in outbreaks and for travelers 10 to 14 days before scheduled visit, like Hajj pilgrims. Next is zoster vaccine. This vaccine reduces the incidence of herpes zoster, a disease caused by reactivation of varicella virus, zoster virus, which is also responsible for chickenpox. It is recommended for 60 years and above as a single dose of live attenuated vaccine, 0.65 ml subcutaneous in deltoid. Next is varicella vaccine. This is a chickenpox vaccine are for all those who are not immunized and all those also who are immunized in childhood. Actually, it is a childhood vaccine, and they say that the immunization is it can be repeated in the adulthood also. Boosters are not needed if the titers are adequate. 2 doses of live V2V or OCA strain are given 4 to 8 weeks apart. Rabies vaccine. Rabies is an acute viral disease which causes encephalomyelitis. It is transmitted to humans through close contact, through saliva and animal bites. In India, about 20,000 human deaths occur due to rabies annually. I am going to talk only about the pre-exposure schedule. 3 doses of vaccine, 0, 7, and 28 days. 3 types of vaccines are present. Human diploid cell culture vaccine or HDCV is given 1 ml intramuscularly. Purified chick embryo cell vaccine or PCECV is given again 1 ml intramuscularly, and purified vero rabies vaccine. The duration of immunity is 2 to 3 years, and boosters should be administered when titer falls below 0.5 MIU per ml. MMR vaccine. Mumps, measles, and rubella are mild form of childhood disease. They can cause severe complication leading to death in adults. Even if you are immunized in childhood, it doesn't guarantee lifelong protection. Adults born before 1957 are considered to be immune to measles and mumps, but still it is advisable to take this vaccine in their adulthood. CDC advises adults to have vaccine in spite of the fact that they are immunized in childhood. If a non-immunized pregnant woman has rubella, she could have abortion or babies born with serious birth defects, and a boy having mumps can have serious effects leading to infertility and sterility. Adults should get 2 doses of MMR vaccine 4 weeks apart. Hepatitis A vaccine. This is available in 2 forms as inactivated vaccine with single antigen called HAV, or it is also combined vaccine with HAV and HBV. Universal immunization is not recommended. Only those with high risk need the vaccine. So these are some of the ACIP adult immunization schedule, the age-based recommendations in India. So with this, we can see that most of the vaccines, they are important for the adult age also. So with this, I could even talk about cholera and typhoid vaccines. And of course, I should not leave the COVID vaccine, which is recently, I'm sure everybody is aware of. And with this, I close my vaccination chart. Thank you very much.
Wonderful, madam. That was a very nice Very nice literature, madam. Totally, you have told all the thing about the doses, who are the beneficiaries, and what all the vaccines available. You show us all the schedules. Okay, and in the adult population, if there is no lifelong protection, it has to be repeated in the adulthood that you have enumerated very well, and certain bottlenecks, what all the things that are hindering to give vaccination. You enumerated that very nicely, madam. And at the end, the support from the government, the policymakers, the politicians are all needed for a successful program of this. Immunization, and nothing you left, madam. That was a very nice one. Each and every slide is very important. Thank you, madam.
Thank you.
And can I summarize, madam? Is it needed to summarize again?
Okay.
Madam told
Okay.
very nicely
Yes.
about that. And
Very nice.
so some are recommended in pregnancy, some are not. Who, at what timings, at what trimester of pregnancy we have to give, and if not given, what will happen, like birth defects in affected rubella during pregnancy. Everything you have told, madam. That's a wonderful, nice enjoyment of a wonderful evening, madam. Thank you, Sudha, madam.
Thank you. Thank you.
Thank you, Sudha. It is really a nice presentation as far as adult immunization is concerned. But I would like to say just a point for specifically for menopausal women. 4 things you should remember: annual influenza vaccine, TD booster dose every 10 years, pneumococcal vaccine once after 65 years, single dose of zoster vaccine in 60 plus women, and obviously COVID vaccine. Okay, these are all the things specifically for menopausal women. Thank you.
Super.
So that you have done
Super.
it very nicely.
Thank you, madam.
Now I have made it a point that every meet, one of our members should participate as a speaker.
Sure, madam. That's a good idea, madam.
Madam, this is my first attempt.
Good. Let's say we want to bring you all to light. Okay.
Enjoyed the lecture, madam.
Thank you. Thank you.
Every slide has to be preserved. And madam's further addings by RJ madam is also very good. During menopause, what all the vaccines are recommended, she added in a nice way.
Thank you. Lakshmi, shall we move on to the next speaker?
Maha, can you introduce the next speaker? Dr. Mahalakshmi?
Hello. Hello, am I audible?
Yes.
Am I audible?
Yeah, you're audible.
Happy to introduce Dr. Niranjan Raghavan sir. And very specially, it's very feel glad to introduce sir, because our president madam's son-in-law. I'm very happy to introduce you, sir. Presently, sir is the professor in the Department of Orthopedics of Savita Medical College. He has the postdoctoral fellowship in spine surgery, and he has published many papers in national and international peer-reviewed journals, as well as in many conferences he has presented papers. He is a PG teacher, guide and examiner for UG and PG students, and he is a reviewer for the PubMed Index journals, for many journals. He is the winner of the multiple medals. Oh, this is wonderful, awesome. He is a winner of multiple medals at UG and PG graduate and postgraduate level. We welcome you, sir, in this wonderful evening in our menopause platform. Welcome you, sir. Hello, Dr. Raghavan, sir. And Kritika Meenakshi is our PG student at Madurai Medical College, madam's daughter.
Dr. Niranjan, you can start sharing your slide.
You are not audible, sir.
Hello.
Hello, hello. You are
Um,
audible, sir. Yes, yes. But your slides are not seen.
That is what I'm trying to
Your
share.
audio is not seen. You are not visualized.
Am I visible now?
No, no.
You are visible, but slides are not coming.
Okay,
Not yet
share
started
my screen.
sharing the slides.
Already on. Okay.
Yes, sir.
Yeah.
You just go to slideshow if you don't mind. Yeah, correct.
Yeah, it is seen, sir. The first slide is seen. Yes, introductory slide. Yes.
Hello. Good evening. I'm Dr. Niranjan. I thank the organizing team for giving me this opportunity to talk about maintaining bone health in menopause. A brief introduction. Osteoporosis is the most common and most overlooked postmenopausal problem. It causes fragility fractures. Incidence in the US is about 30%. In India, as with most things, we have inadequate data. The estimated range is between 40 and 60%. I have shown you a sample of a healthy bone and an osteoporotic bone. You can see the difference in the bone architecture. This is a common problem that most of us face. We have seen as gynecologists, I am sure you will all be aware of following up people for a very, very long time. The daughter gets born, daughter becomes pregnant, the daughter of the daughter gets born, and the cycle goes on. So when we see them for a longer duration, we see that they were a bit straight, started bending, further stooping, and fully stooped. So this is a common progression that all of us have seen, and osteoporosis is the reason why this happens. The problem why we want to avoid osteoporosis is we want to prevent this from happening. This is an example of an osteoporotic wedge compression fracture or a fragility type fracture that is caused without any significant trauma. It's a silent disease. It has got leads to low bone mass and structural deterioration of bone tissue, increases in bone fragility. Most common seen fractures are spine, hip, and wrist. I have shown you an example of another multiple level osteoporotic wedge compression fracture. This leads to significant pain and disability. Osteoporosis and menopause, as you are all aware, estrogen, a female hormone, protects against bone loss. After menopause, the ovaries produce very little estrogen. This decrease in estrogen triggers a period of rapid bone loss, which starts 1 year prior before the final menstrual period and lasts for about 2 years. The natural effect of aging of bones may contribute to this problem. This is a classification of osteoporosis. Osteoporosis is usually classified into primary and secondary types. The primary type or the idiopathic or age-related type. The secondary type is maybe due to endocrine causes, drugs, chronic diseases, malignancy, nutritional deficiency, etc. The WHO classification of osteoporosis is dependent on the bone mineral density score taken with the help of a DEXA scan. The DEXA scan is a whole body CT scan which measures the amount of bone mass that is seen in the patient. The classifications are based on the T score. The T score is classified as normal if it's less than -0.1, and osteopenia is between -1 to -2.5. Osteoporosis is -2.5 below. And now the classification is osteoporosis plus or established osteoporosis, where there is a score of -2.5 and a fragility fracture concurrently. Risk factors for osteoporosis, some of them are modifiable, some of them are non-modifiable. The modifiable risk factors are age, female ethnicity, Oriental and Caucasian population, premature menopause less than 45 years of age, family history of osteoporotic hip fracture in a first degree relative, personal history of a fracture as an adult, long-term steroid therapy, and rheumatoid arthritis. Modifiable risk factors are most common sedentary lifestyle and smoking, excessive alcohol, excessive caffeine, low BMI, estrogen deficiency, impaired vision, recurrent falls, and low calcium or vitamin D intake. This is a screening tool. This is called the osteoporosis self-assessment tool for Asians. This is used to identify candidates who need FRAX assessment and BMD scan. As you can see in the slide, the more concerning problem is low BMI. Although we are made to believe many times that it is the obese and the overweight people who are more at risk of osteoporosis and fragility fractures. But in reality, what happens is low BMI causes more osteoporosis because of the total volume of bone that is present in those candidates are much lesser. So low risk of osteoporosis is when the weight in the 40 to 44 age group exceeds it is more than 40 kilos, there is low risk. So you can see the chart. These are used for screening women using OSTA. Basic investigations, total blood count, ESR, serum calcium phosphate albumin, ALP, RFT, and a plain X-ray. This is the FRAX or the fracture risk assessment tool. It estimates a 10-year probability of fragility fracture. We have now developed country-specific FRAX prediction algorithms. BMD is usually not necessary, but may be used to improve prediction. If used, total femoral neck or total hip BMD is used. This is the FRAX tool. This is available free online. We can just enter the data and we'll get a percentage. Bone mineral density can be measured using two types. One is the DEXA or the dual energy X-ray absorptiometry. This is the gold standard. We measure using hip and spine and get a complex number, which is calculated by a computer. The QCT or the quantitative CT measures only the vertebral volumetric bone density, but it needs a higher radiation dose and therefore it's not routinely used. Maintaining bone health, as all of us know, nutrition, sunlight, vitamin D, calcium, body weight, caffeine, smoking, alcohol, and exercise are important components in maintaining bone health. Secondary fracture prevention and primary fracture prevention, the algorithm that we use is as follows. Age less than 50 years, we are not bothered as of yet. Age more than 50 years with a fragility fracture. If it's a hip fracture, vertebral fracture, or some other fracture, then we move on to a DEXA scan. Then we decide if the patient needs bisphosphonate therapy or denosumab, or the patient needs teriparatide. This is the ACOG recommendation in women more than 65 years. Patient with above 65 years of age need to undergo one DEXA scan. With additional risk factors, we can consider DEXA scan earlier. This is the NICE guidelines, quality statements for osteoporosis. Adults who have had fragility fractures or use systemic glucocorticoids have a history of falls, need an assessment of fracture risk. Statement 2 is adults at the risk of fragility fracture are offered drug treatment to reduce fracture risk. Statement 3 is adults prescribed drug treatment to reduce fracture risk are asked about adverse events and adherence at each review. And statement 4 is adults having long-term bisphosphonate therapy need to have a review for continuing treatment. These are some of the interventions that are commonly used to treat and prevent osteoporosis. A balanced diet with adequate calcium and vitamin D, reduced salt intake, and some exposure to sunlight. The sources of vitamin D commonly are red meat, egg yolks, and salmon. For calcium, it is milk, spinach, and chia seeds. How much of sunlight? This is a question that we get commonly asked. Fair-skinned people require 20 minutes of sunlight exposure 3 to 4 times a week, and at least the hands and the face have to be bare. Dark-skinned people need more sunlight. They need 30 to 40 minutes of exposure 3 to 4 times a week. For optimum exposure, 20% of body surface area needs to be exposed to sunlight. Contrary to popular expectation, the ideal time for sun exposure is between 11 and 2 p.m. Earlier, we were of the impression that the exposure was better in the mornings and the evenings. Nowadays, we find it proven in multiple studies, it's best between 11 to 2 p.m. And keep moving. Please don't sit in one place. This can lead to sunburn. Calcium, check your daily requirement. Women age 50 plus need a requirement of about 1200 milligrams per day in divided doses. As for absorption, calcium carbonate has the most elemental calcium. Tricalcium phosphate is almost similar. Citrate, lactate, and gluconate have much lesser elemental calcium levels. Vitamin D, for optimal musculoskeletal health, we need a vitamin D of about 30 nanograms per ml. This is nowadays disputed in India because just like the small for gestational age babies, which we used to consider as more than 3 kilos, which got revised to 2.5. This is, people are starting to get the impression that 20 is sufficient in the Indian population, although there are no blinded studies as of yet to get the optimum value. For people greater than 50 years of age, 80 to 1000 international units are required. Available as ergocalciferol vitamin D2 and cholecalciferol vitamin D3. For daily treatment, D2 and D3 are equally potent. For weekly or monthly dose, D3 is more than D2, 3 times more potent. Body weight, low body weight because of excessive dieting, low mineral status, increased fracture risk. To prevent, please maintain a BMI of more than 19 kilograms per meter square. Caffeine is a common problem, especially for people involved in surgical work. Coffee is the adrenaline on which we run. We are advised to limit caffeine to 1 to 2 servings per day. More than that causes a decreased intestinal calcium absorption and increased intestinal calcium excretion. How much caffeine is in a drink? One regular cappuccino is 1 espresso shot. A long black is 2, and the others are just given here. Decaf caffeine has 0 espresso shots. Smoking and alcohol should be avoided. Exercise, regular physical activity improves musculoskeletal health. Weight bearing exercises, brisk walking, 40 minutes a day, 3 times a week. 120 minutes of exercise is recommended. Strength training is something that significantly improves bone health, and people who can start strength training need to be advised to start strength training at the earliest. There is a big taboo here about strength training, and especially among women, that strength training leads to more masculine features, although this very rarely happens. Pharmacotherapeutics, the common options are HRT, Tibolone, SERMs, bisphosphonates, RPTH, and denosumab. This is a chart that shows the quality of evidence for each treatment option available. Calcium and vitamin D supplements are category A in VMD improvement, vertebral fracture risk reduction, and distal radius risk reduction. And estrogen, the same way. Alendronate and other zoledronic acid and other bisphosphonates, denosumab, are all category A. RPTH does not decrease distal radius fracture risk. Comparison of estrogen related drugs for bone mineral density, Tibolone, Raloxifene, and estradiol are compared in this study, and the best option is available for estradiol, and bone markers best option again is estradiol. However, when the side effects are concerned, this is a chart. All of you must be pretty aware of this. I don't have to elaborate much on this. It is a side effect of these drugs and which receptor acts where. So you can follow this right. Current recommendations: low-grade osteoporosis or prevention of fragility fractures, bisphosphonates oral, that is alendronate, weekly once for 8 weeks. Here, the problem with giving alendronate is the patient must be asked to sit after alendronate consumption early in the morning for a period of between 60 to 90 minutes. Now, this becomes a problem for a lot of people because to sit still for 60 to 90 minutes is an arduous task in itself. So, if they are not able to tolerate oral bisphosphonates or are unable to maintain
some interruption, it's not audible.
Network.
Hello, Dr. Mohan. Some interruption is there, it's not audible.
Hello, any net connectivity problem? Any net connectivity issue? You're not audible. Audible.
Hello, am I okay now?
Yeah.
Yeah.
You can start.
Phone button. Hello. Yeah.
Yes, it is audible. Yeah.
Okay. Is my screen visible?
Yes.
Okay. So the current recommendations I was talking about. If they are unable to tolerate oral bisphosphonates, we give them zoledronic acid once a year. This requires IV infusion, and this needs to be done on an inpatient basis. Patient ideally needs admission for a day. We need to work up the patient's urea and creatinine levels before we give the infusion. And for the infusion to be given, we need to prehydrate the patient with 1 point of fluid minimum. Then infuse the zoledronic acid over 2 to 4 hours, and then top it up with another point infusion over another 2 to 4 hours. So this is a 6 to 8 hour infusion that is ideally given once a year. Okay. Moderate osteoporosis, current recommendations are nasal calcitonin spray. Here, this is a good option for patients who cannot take oral alendronate. The problem here is this needs to be given 42 days at a stretch, once per day, 1 puff only. Here, the problem is the nasal spray does not produce too much of an odor. So, a lot of people tend to press it multiple times, and this leads to an overdose of the drug. So, they have to be clearly instructed that they have to press only once and use alternate nostrils on each day. And not to stop the drug for 42 days, whatever happens in between. So, this needs a lot of education, and this needs a compliant patient. Recombinant PTH or teriparatide, 8 micrograms subcutaneous once daily is currently considered the gold standard. Very effective for treatment of osteoporosis, especially the severe category. The problems are, this is a high cost treatment. Every month, minimum cost is going to be 5,000 to 7,000 rupees. And the first time the patient has to buy a pen. So the total for 3-month program, the minimum expenditure will be about 15,000 to 16,000 rupees. One. The second is the patient needs to be counseled for daily injections, and the patient needs to be educated regarding sterile technique. Third, this needs to be stored in a refrigerated setup. So the patient needs to have a proper fridge with a proper current supply. Otherwise, the drug can go waste. Fourth is the patient, once the vial is opened, needs to be used within the 35 days. So the 28-day dose needs to be completed within 35 days. Beyond this, the drug loses its potency. However, on the flip side, patient has very, very low incidence of side effects. The problem with long-term oral bisphosphonates is there is a increased propensity to develop atypical femoral shaft fractures. That is very, very difficult to treat, because the drug that is supposed to prevent fracture is now causing the fracture. So this is going to end up with a lot of trouble for us. To fix such a fracture takes a lot of difficulty because it doesn't heal well enough. However, with recombinant PTH, such side effects are very minimal, and patients can be given RPTH despite poor urea and creatinine. In fact, the only contraindication in postmenopausal women is dialysis or stage 5 CKD or a patient on renal transplant. This is the only contraindication to usage of RPTH. Take home message: don't avoid calcium intake, stop avoiding sunlight, reduce salt intake, avoid a sedentary lifestyle, avoid alcohol, and avoid smoking. I'm open to questions.
Thank you, sir. That was a wonderful lecture. Dr. Shivakami? Dr. Shivakami? Are you there?
Yes, it was a wonderful lecture. But the thing is that we had a lot of disturbances, madam. Very, very nice points he was explaining, but still we couldn't get the entire thing in full form because of a lot of disturbances. But anyway, let me summarize if I am right. We all know that it is osteoporosis is about, has an incidence of about 60%, and it's a silent disease causing fractures of spine and hip, wrist. And the commonest cause is because of the age-related problems in the bone and the estrogen reduction. And the estrogen reduces 1 year before the menopause, and then along the first 3 years after menopause. And always it is by the DEXA by which you categorize. And we have to have the life pattern in such a way that we don't have sedentary life. Caffeine should be reduced. Alcohol smoking, no. We should have vitamin D, calcium supplements, and low BMI is important, and brisk walking and strength training should be there. And in case of low grade osteoporosis, biphosphonates will be the treatment of choice. And orally, if they are able to tolerate alendronate, it is okay. Otherwise, it is zoledronic acid. And for moderate osteoporosis, it is a nasal calcitonin spray for about 42 days. But of course, the cost is a problem. And for a very effective treatment will be the parathormone, 8 micrograms subcutaneously per day for 3 months. Again, this is also the cost affordability will be a problem. And so the take home message will be, we have to avoid smoking, avoid alcohol, avoid sedentary lifestyle. Salt intake must also be reduced. And the most important is exposure to the sunlight for about 40 minutes. And so that we get the exposure of 20% of the body surface area. And with all these points, I think I've made a small summary of what he has said. It was all full of knowledge, madam. And anything, madam, please, you can add on.
Is
Madam,
Dr.
am I
Niranjan
audible?
there? Is Dr. Niranjan there available?
Yes, yes, madam.
Yes, yes. Now our members would like to know, so you are talking about all these drugs, but as such, for as doctors, that is busy practitioners, what best we can do or what best we can take once there is osteopenia or mild osteoporosis?
For mild osteoporosis or osteopenia, the best treatment or the best preventive method is exercise. Exercise needs to be started at 5 or 10 minutes per day, 2 times, moving on to about 40 minutes per day. The issue here is most often what happens is we start off with exercises, the exercises become painful, and this leads to a cycle. Exercise, pain, stop exercises, more pain, and just keeps rolling on in a cycle. So to start off, keep the time limit very low, and easy walking is the usual initial aerobic exercise that is suggested. Once we are okay with moderate to brisk walking for 40 minutes every day, then we move on to strength training. So this combination is what is ideally recommended for sedentary people who are yet to start off on a serious exercise program.
Thank you. Calcium routinely 1000 daily till the end.
Calcium routinely 1200 milligrams is recommended. But on the other side, we see a lot of patients who have taken a lot of calcium and ended up with renal stones. So that is a double-edged sword.
Dr. Subhashini. Subhashini, she has raised her hand to ask something.
Yeah.
Subhashini, are you there? Subhashini, she's not there.
Unmute and ask your questions, ma. Subhashini. Any more questions in the chat box, madam?
Nothing. Subhashini raised her hand, but I don't know. She is not able to talk.
Yeah, Subhashini can post the question in the chat box so that we can read it. Subhashini, Dr. Subhashini, you can post the question in the chat box so that we can read it and answer. So the faculty can answer.
Sir, what is the format we can use for risk assessment, sir, in our daily practice?
The FRAX tool,
this is my question.
The FRAX tool is easily available online free, madam. The only things that are required are history of the patient, the height and weight, and we enter these details online. India specific results are available free. You can even save it, print it out, and give it to the patient for follow-up. So FRAX is the tool of choice for evaluation.
Just these factors are enough. Age, weight, and
Age, weight, height, and and history, and family history, personal history,
Ah.
smoking, alcohol, all of those things. History is needed. Age, weight, and height are needed.
Oh, okay, okay, okay. Thank you, thank you.
The question is, there is one question from Subhashini. Is personal trainer a must to start strength training or weight bearing exercise?
Personal trainer is a luxury. Yes, if you can afford it, fine. If you cannot afford it, start off on your own. There are enough YouTube videos available where simple dumbbell exercises for each of the specific muscle groups are available. And there are a lot of free apps available which enroll people onto the ecosystem and provide with simple exercises like Fitter, Fit On, and so on and so forth. So if you can afford a personal trainer, fine. Otherwise, it doesn't really make too much of a difference for initial levels at least. Once you are into serious professional training, then fine. Then yes, it does make a difference.
Next question: will HRT postpone osteoporosis?
HRT does not postpone osteoporosis because as orthopedic surgeons, we don't give HRT on a regular basis. We prefer giving them alendronate or salmon calcitonin. Our experience with HRT is very minimal, except if HRT is otherwise indicated. Just for osteoporosis, there are much safer drugs.
We gynecologists prefer hormone therapy for 3 indications: estrogen therapy, one is vasomotor reflex, and genitourinary problem, and bone problem. For these 3, HT, that is hormone therapy, is indicated.
Okay.
I think, madam, when they have symptoms, menopause symptoms with osteoporosis or osteopenia, then you can give.
Yes.
If they don't have, symptomatic menopause symptoms, they can straight away go on to bisphosphonate. If they have vasomotor symptom or genitourinary symptom with osteoporosis, the better drug will be hormone.
Yeah, that is
Maha,
surrounding 1 year of menopause. What do you mean is surrounding 1 year of menopause?
No, hormones are indicated only up to 60 years if there is no contraindication. That too only for symptomatic women. Menopause symptoms like vasomotor symptoms or genitourinary symptom, only then we can prescribe menopause hormone, not for everyone. That's why the terminology itself has changed from hormone replacement therapy to menopause hormone therapy. It's not something like insulin. So only for symptoms, we will be giving menopause symptoms. We have to give estrogen up to the age of 60 years, not later than that.
Okay, that's clear, madam.
Some more questions are there, madam. Zumba or any form of dance, is it okay for female after 40s?
Yes,
yes, madam.
Yes, of course. We have to.
Yes, of course.
You can do it with pleasure. Okay.
Then they will do it definitely when there is a Zumba and there is a crowd. They'll definitely do it.
We'll be motivated to participate in that. And in severe pain due to osteoporosis, any drug of your choice is another question, madam.
My drug of choice would still be teriparatide. Teriparatide decreases pain associated with osteoporosis, especially after spinal fracture. That's the most common place where patients have severe pain. So osteoporosis decreases the pain and helps in healing. So single drug does both.
Okay. Another question: calcium citrate, does it cause renal calculi?
All forms of additional calcium have a propensity to cause renal calculi.
It should be in appropriate dose, madam. If they are taking too much dairy products, they have to calculate the daily requirement actually. If they are taking nice curd, all that, and then 1200 on top of it, then it becomes excess. If it is an ideal daily requirement around 800 to 1000, calcium citrate is better than any other drug.
There's another question from Dr. Savitri. Simple treatment for back pain.
Identify the cause.
Every woman has got a back.
Back pain is a multimodal problem. It is very difficult to be put in one box. So the pain could be from bone, it could be from the disc, it could be from the joint, it could be from the nerve, and so the treatment will vary depending on what is the pain generator. So this needs a thorough clinical examination to find out what is the cause. Most common cause of back pain is mechanical or postural back pain, where we don't sit properly, we don't sleep properly, we don't walk properly, we are stoop while sitting, we are stoop while walking. So that needs postural correction and education. That is the most common type of back pain. But ideally, back pain treatment is dependent on what is the cause.
Well said, well said.
Back strengthening exercises can be utilized, no, sir?
Yes,
Provided
absolutely,
you are
madam.
ruling out other disc problems and all.
Even
After
with this
ruling out
even
disc
with this
problem.
problems, back strengthening exercises are treatment of choice. Only thing is we need to initially give them a couple of weeks to reduce the pain. Some painkillers, some specific directed tablets. Once the pain is manageable, back strengthening exercises are the mainstay of treatment for disc problems. Long-term benefits come from back strengthening exercises.
So one more question, can rheumatoid arthritis and osteoarthritis both will combine together? Can occur in a patient, sir? Rheumatoid arthritis as well as
Yeah, they can happen, but generally it does not happen. Generally, rheumatoid arthritis destroys the joint well before osteoarthritis comes into the picture. So when osteoarthritis walks in, all it finds is a destroyed, damaged joint. So there is nothing for it to do.
Okay.
Dr. Kamala from Ramnat, she has asked one question. In some patients, parathormone is increased along with osteoporosis. What to do in such a patient other than PTH?
If the patient already has problems with parathormone, that is one of the contraindications for parathormone replacement. So we have to think of other treatment options. But most often, what happens is the parathormone increase itself causes the osteoporosis. So the parathormone increase needs to be identified, like primary, secondary, tertiary hyperparathyroidism, and then the cause identified and then treated. That will itself cause a decrease in osteoporosis.
Alternative drug for osteoporosis in such patients, she's asking.
Usually what we do is we rule out increase in parathormone due to other causes. Commonly renal causes or parathyroid causes. Before we rule out other problems, we do not give them any treatment for osteoporosis, because the treatment is curative if the parathormone levels normalize or whatever caused it to increase in the first place.
Okay, normalizing the parathormone levels. Okay. Nice question and answer session going on.
Lakshmi, are you there?
Yes, ma'am.
If there are no questions, any more questions, or if some more chat box? Something.
I think it's done.
Okay.
No.
So with this, I think we have come to the end of the session. I would like to propose vote of thanks. On behalf of IMS Madurai chapter, I'd like to thank the organizers, Dr. Revathi Janakiram ma'am, President IMS Madurai chapter, and Dr. Angir Kani, Secretary Madurai IMS chapter, and our chief guest, Dr. Hepzibah Kripamani madam, President Chennai Menopause Society, and our chairpersons who made the sessions very lively, Dr. Mahalakshmi, Professor OBG at Madurai Medical College, and Dr. Sivakami madam, Director, Subham Hospital, Madurai. I would also thank our speakers, Dr. Niranjan M. Rahavan and Dr. Sudha Deep, for their enlightening presentation today. I would also like to thank our delegates who made the session very interesting with their interactive questions and day-to-day problems. And I would like to also extend my thanks to our digital partner, Sri Events, and our sponsor, Femostam. Thank you, one and all. Thank you.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you, Hepzibah. Thank you very much.
Nice
So all of
session.
us will leave the session, and I request all our members, Madurai chapter IMS members, to rejoin again for our general body meeting immediately. Okay.
Yes,
Thank you.
madam. Yes, madam. Thank you.
2 minutes, ma'am. I can make everybody's co-host. 2 minutes.
Okay, okay.
Yeah, we done. We removed that. You can speak. Once we finish, you can log out. Leave the program.
Dr.
No
Sumati
problem.
Anand, you raise your hand. Hello? Dr. Sumati? Sumati and Parveen. Dr. Sumati Anand?
Yeah, ma'am. Good evening, ma'am.
Good
Actually,
evening,
I wanted to put a question to him, but I think it got ended.
No, you could have
Just
written,
I can
you could have
ask
put it
you,
in the
ma'am.
chat
Actually,
box. You could have put it in the chat box. What's the thing? Come on.
oh, okay. Can I just ask you, ma'am?
Yes, yes.
மேம் மேம் வந்துட்டாங்கன்னா நீங்க ஸ்டார்ட் பண்ணிக்கோங்க மேம் எல்லாரும். நீங்க மியூட்ல இருக்கீங்க. ரேவதி மேம் நீங்க மியூட்ல இருக்கீங்க. அதே மாதிரி அவன் பண்ண உனக்கு பண்ணாரு. மேம் நீங்க மியூட்ல இருக்கீங்க. எல்லாருமே எடுத்தாச்சு. மார்னிங் செஷன் படிக்கட்டுல இருந்து இறங்கி இந்த பிளாக்ல அந்த பிளாக் கிராஸ் பண்ணி அவங்க சாப்பாட்டு ஏரியா போகணும். பிரணவோட கிளாஸ் எந்த பிளாக்ல இருக்குன்னு தெரியும். பிரணவோட பிளாக்
ஆமாட்டேங்குது. அப்ப இப்பதான் அன்மியூட் ஆகுது. ஓகே ஓகே, தேங்க்யூ.
நடந்துட்டு இருக்கும்போது அங்கே ஆப்போசிட் சைட்ல இருக்கு பிராணேஷ் கிளாஸ். அது அங்கிருந்து இறங்கி மணல்ல கிராஸ் பண்றாங்க. ரெண்டு
How many have joined?
Madam, am I audible?
Yes, yes. Lakshmi. Sumati Valliya, Sumati.
No, அது decorate. அது நல்லா இருந்துச்சு. சேஞ்ச் ஆயிட்டே தானே இருக்கு.
How many are there?
Ma'am, Savitri ma'am. Backla edo TV noise varudhu.
I just am checking whether all members have joined. So I can check attendance. Savitri, Shivagami, Sindru, Nancy, and who else?
Disgrace. You are disgracing yourself. You decent and
அவன் வந்து ஒரு விஎம்டில படிக்கிற ஸ்டூடண்ட் பிஹேவ் பண்ற பார்த்தோம்னா ஹாய் அப்படின்னு சொல்லிட்டு போறது. நீ வந்து திருப்பதியில படிக்கிற அந்த ரோட்ல எல்லாம் காய்கறிகள் விற்கிற நீ வந்து என்ன சாக்கடையில இருந்தாலும் படிக்கிற நல்ல சும்மா படிக்கிறோம் நல்லா பேசுறேன்.
இன்னும் யாருப்பா நம்ம மெம்பர்ஸ் இன்னும் யாரும் இல்லையே.
டீசெண்டா பிஹேவ் பண்ணணும். என்ன என்ன
யாழினி இருக்கா? சந்திரு ஜஸ்ட் செக் பண்ண யார் நம்ம இன்னும் மெம்பர்ஸ் வரணும்னு. லலிதா வரலையா? லலிதா has not joined. சித்ரா எங்க? சித்ராவை காணோம். ஏபி சித்ரா ராஜபாளையம்.
நைட் டியூட்டி பாக்குறாங்க. மேடம், குட் ஈவினிங் மேடம்.
குட் ஈவினிங்.
என்ன மேடம் டிஸ்கஸ் பண்ண போறோம்?
அதுதான் சொல்ல வரேன் நானு. பட் எங்க நம்ம மக்களே இன்னும் யாரையும் காணோம்.
அப்படியா? Chandru. Good evening. Good evening, Chandru.
சரிப்பா. மகாலட்சுமி எங்க? யாழினி, லக்ஷ்மி,